Hello, good afternoon, good evening. Today we'll be discussing on obstetric socks or sock in obstetric. Let me just check my mic and my presentation. So we all medical professional knows about the shock, and this is a very dreaded complication. It is defined as a state of circulatory inadequacy with poor tissue perfusion, and it results in generalized tissue hypoxia. There will be always a disparity between the circulating blood volume and capacity of the circulatory bed. So the net effect will be inadequate exchange between oxygen and carbon dioxide between intra and extravascular compartments. And it is no different in obstetric cases also, but in few cases there are few extra causes of shock in obstetrics than in the general population. So before discussing about what is the difference between the general population shock and obstetric shock, we need to know about the changes in system that occurs in pregnancy, which will be leading to difference in the management, and also very small events can cause the exaggeration of shock. So the changes of pregnancy related systems are the plasma volume will increase up to 50%, and so there is usually a dilutional anemia and reducing, which again reduces the oxygen carry capacity. Also, there is increase in heart rate by 15 to 20 beats per minute. So usually tachycardia is the first sign in shock, which is present in pregnant women by already it is present. So it will increase the demand during cardiopulmonary resuscitation. Similarly, output is also increased by 40%, and uh, as there is pressure by gravid uterus over inferior vena cava, so cardiac output will be reduced, and then thus during CPR there is increased demand. Also, uterine blood flow is increased, or uterine blood flow is 10% of the cardiac output at down. That is almost like 500 ml per minute. So this is the potential site for rapid massive hemorrhage. Similarly, systemic vascular resistance is decreased. That is, the blood is pulled peripherally. Also, the arterial blood pressure is decreased by 10 to 15 millimeter of mercury, and there is decreased reserve. Similarly, venous return, there is a decrease of venous return due to the pressure by gravid uterus. Similarly, respiratory rate is also increased during pregnancy, and it will decrease the buffering capacity, and metabolic acidosis is more likely in pregnant women. Oxygen consumption is increased by 20%, because of which hypoxia also develops quickly, and residual capacity is decreased. Hypoxia develops more quickly. Arterial carbon dioxide is also decreased, and laryngeal edema is increased, which causes difficulty in intubation. And other changes like gastric motility is decreased, because of which there is increased risk of aspiration. Lower esophageal reflux is more relaxed, and increased risk of aspiration. Uterus is enlarged, so that the diaphragm takes splinting, causes decrease in residual capacity, and it makes ventilation more difficult. And also the aortocaval compression, which causes supine hypotension, significantly impairs cardiopulmonary resuscitation. And weight due to large breast, this may interfere with the intubation and ventilation. The classification of shocks, we can classify them into five groups, that is hypovolemic shock, cardiogenic shock, four groups: hypovolemic shock, cardiogenic shock, obstetric shock, and distributive shock. And out of distributive shock, there are again different types like anaphylactic shock, septic shock, and neurogenic shock. So this is the picture that depicts causes of maternal collapse, starting from head in eclampsia and intracranial hemorrhage, and then the anaphylaxis, and drugs like magnesium sulfate, uh, or IV anesthetic drugs, local anesthetic drugs, or drug abuse. Similarly, in the chest, pulmonary embolism, ear embolism, amniotic fluid embolism, or aortic dissection. Some cardiac causes like arrhythmia, myocardial infarction, cardiomyopathy. Then hypoglycemia, sepsis, and hemorrhage like splenic artery rupture, hepatic rupture, uterine antepartum hemorrhage, postpartum hemorrhage. These all are the causes of maternal collapse. So there is a mnemonic C can die, which gives the general causes of obstetric shocks: S for sepsis, H for hemorrhage, E for embolism, C for cardiac cardiac causes, A for anaphylaxis, N for non-pregnant causes like 4H and 4Ts, that are the common causes, and D for drug toxicity, I for intracranial hemorrhage, and E for eclampsia. So let's begin with hypovolemic shock. First of all, we'll have the general overview of different causes and different types, and then we'll go with the management. So regarding the hypovolemic shock, this is due to inadequate volume of the circulating blood. So there will be acute depletion in the blood. Causes of hemorrhagic causes of sorry hypovolemic and causes will be hemorrhagic and non-hemorrhagic. In hemorrhagic cause, the excessive bleeding or bleeding loss in early pregnancy, like abortion and small ectopic, antepartum hemorrhage, postpartum hemorrhage, inversion of uterus, ruptured uterus trauma. And in non-hemorrhagic, there will be fluid loss, like in case of excessive vomiting, diarrhea, supine hypotension syndrome due to compression of inferior vena cava by the pregnant uterus. Also, cardiogenic shock, when there is a failure of heart, when there is failure of heart to provide the adequate output, when there is failure of heart to provide adequate output, which leads to tissue under perfusion, and there will be back pressure on lungs, which leads to pulmonary edema. Failure of heart to provide adequate output, which will lead to tissue under perfusion, and back pressure on lungs leads to pulmonary edema. Causes are myocardial infarction, cardiac arrhythmia, aortic dissection, cardiomyopathy, acute left ventricular failure, and infected endocarditis. The other is obstructive shock. So any causes causing obstruction uh, to the cardiac or pulmonary circulation, like cardiac tamponade, tension pneumothorax, air embolism, amniotic fluid embolism, and pulmonary embolism, which we'll be discussing in coming slides. Septic shock is this is the refractory hypotension which occurs in due to sepsis, that is infection, which will cause the derangement in cellular and organ system, and it will persist in spite of adequate fluid resuscitation. So maternal mortality is up to 13% in sepsis and up to 30% in septic shock. So the causes are septic abortion, prolonged rupture of membrane leading to chorioamnionitis, so manipulations and instrumentations, trauma causing perforation of uterus with peritonitis, retained placental tissues, puerperal sepsis, surgical site infection, and severe acute pyelonephritis. And also some causes of neurogenic shock, like in case of disturbed ectopic pregnancy, in concealed accidental hemorrhage, in forceps or breech extraction before full cervical dilation, rough internal version, rupture uterus, acute inversion of uterus, or rapid evacuation of uterine content, Imprecipitate labor or rupture of membrane in polyhydramnios. These all causes can cause neurogenic shock. And also some other causes like chemical injury, in which there is aspiration of gastrointestinal contents during general anesthesia, aspiration pneumonitis, drug toxicity and overdose, usually anesthetic drugs or magnesium sulfate, or spinal cord injury, which can produce hypotension and shock as a result of sympathetic nervous system dysfunction and loss of sympathetic tone, which will cause widespread vasodilation, also known as spinal shock. So also shock can occur during any type of anesthesia or analgesia for labor or delivery. And shock caused with an anesthesia is usually due to adverse shock reaction and anaphylactic shock or the high spinal block. It occurs when there is overdose of local anesthetic drugs is administered into epidural or subarachnoid space. And anaphylactic shock, it is a severe, life-threatening, generalized, and systemic hypersensitivity reaction which will cause in respiratory, cutaneous, and circulatory changes and lead to collapse. So there will be intramuscular volume redistribution, so which will cause decreased cardiac output. Upper airway obstruction will cause due to angioedema, bronchospasm, mucus plugging of smaller airways leading to hypoxia and difficulties with ventilation. And common triggers are drug, latex, animal allergens, and foods. And anaphylaxis is likely when all of the criteria are met, that is, there is a sudden onset and rapid progression of symptoms, and there is life-threatening airway or breathing or circulation problems, skin or mucosal changes like flushing, urticaria, angioedema, and mass self-tryptase level can be useful in confirming the diagnosis when three samples are taken uh, at a distance of or 1 to 2 hours apart. And there is a system developed for early warning, that is modified early obstetric warning systems are MEOWS, also known as MEWS, which gives the criteria in which will help to recognize the clinicians and the early signs and symptoms of shock. So and there are three zones: white zone, yellow zone, and red zone. In white zone, the respiratory rate or breath is 10 to 20. In yellow zone, 21 to 30. And in red, it means less than 10 breaths per minute or more than 30 breaths per minute. And oxygen saturation is 95 to 100% is normal, and less than 95% falls on red zone. Temperature 36 to 38, 35 or to less than 36, or more than 38 or less than 35, that is either fever or hypothermia. And heart rate is between 50 to 100 is normal. If more than 100 to 120, or 40 to less than 50, and less than 40 bradycardia, and more than 120, that is tachycardia. For systemic blood pressure, 100 to 140 is normal, 90 to 100 and 140 to 160 falls in yellow zone, that is we need to be alert, and less than 90 or more than 160 which falls on red zone. Similarly, diastolic blood pressure less than 90 is normal, 90 to 100 is yellow zone, and more than 100 is red zone. Proteinuria nil stress 1 or 2 and more than 2 plus is significant. And if it is clear, it is white, and if it is green, that is meconium stain, that comes in red zone. Neural response, patient is alert or response to neural response from ABPU, alert, response to vagus if unresponsive or response to only pain, then that is red zone. And look healthy or false smelling, and in general condition looks well, looks unwell. These are all the criteria that should be looked upon. The general clinical picture of the shock is usually the patient has low BP and rapid weak 3D pulse with pale, cold, clammy skin, sweating, sinuses of finger or ear hunger, dimness of vision or dizziness can be present, restlessness, confusion, oliguria or anuria may be seen. And whenever there is suspected shock, then we will send the basic investigations like a complete blood count with hemoglobin and blood grouping cross matching should be done. Renal function test, liver function test, blood sugar, serum electrolytes, ABG, acid blood gas, and urine analysis is done. So management is call for help. It requires a teamwork which involves senior anesthetist, obstetrician, physician, neonatologist, and intensivist. And active management should start as soon as suspicion or because we aim to restore the tissue perfusion and oxygenation as soon as possible. And the systematic approach with modification for pregnant women. So this is the algorithm that shows. This is the algorithm that is taken from Green Top guideline that shows the method that shows the steps that needs to be taken when maternal collapse occurs. That is, it is similar to cardiopulmonary resuscitation in any adult, but there are some modification that will be discussed. So, is the environment safe? If yes, then we will. The first thing is will ensure the manual uterine displacement or left lateral tilt. Usually, in left lateral tilt, it is difficult to perform the cardiac compression. So, another assistant, a person will just lift, displace the uterus to the left to prevent the aortocabal compression. Call for help. Then we'll assess for airway, breathing, circulation, and fetal heart rate, and regular assessment using modified early warning system, and we'll identify the cause of collapse and treatment. And if the patient is not responding, then then that means that airway is also compromised. So we'll call for help. Then we'll open airway. For open airway, we can check for obstruction and perform the maneuvers like head tilt and chin lift. And we'll assess the breathing for up to 10 seconds by look, feel, and look, listen, and feel. Look for chest movement, listen for breath sounds, and feel for air. And if the patient is breathing normally, we can turn into recovery positions and again continually assess with breathing pulse, BP, fetal heart rate, and regularly assess and identify the cause and treat. And if the patient is not breathing, and we have already seen for 10 seconds, then we'll begin chest compressions or cardiopulmonary resuscitation. So before that, we need to ensure the manual displacement of uh, uterus or left lateral tilt. So we might require three persons at a time in a pregnant woman. One will be doing the airway maneuver, the other with chest compression, and the other with uterine displacement. So chest compression rate is same, that is 30 compression in 100 minutes. Sorry, 30 compression in one cycle with rate of 100 per minute, and a deep dish of 5 to 6 centimeter at center of the chest with ventilation, to ventilation, and defibrillator or monitor can be attached. And then also mouth to mouth resuscitation only if airway agents are available. Two attempts at ventilation to minimize the interruption. And now, once the defibrillator or AED is available, we'll attach it. It will assess the rhythm, and if there is oscillatory or pulseless electrical activity, um, then shock is not given. So only CPR, uh, that is in 30:2 for 2 minutes, and if there is ventricular fibrillation or pulseless ventricular tachycardia, then shock is given. One shock with 200 joule of biphasic or 360 joule of monophasic, and again the CPR is resumed with 30:2 cycle for 2 minutes. And also during this, we need to establish IV access either by white bore cannula, or it can be If not, IO, intraosseous access, and also high flow oxygen. If not breathing, then intubation is required with continuous chest compression, correcting the reversible cause, and also adrenaline is given one ampoule every 3 to 5 minutes, and other considerations like amiodarone, atropine, magnesium, and 4H and 4Ts. And also in pregnancy it is E also, that is 4H is hypoxia, hypothermia, hypoglycemia, and hyper or hypokalemia. And 4T's are thrombosis or thromboembolism, toxic or therapeutic causes, cardiac tamponade, and tension pneumothorax. And E stands for eclampsia. And if the patient or if the collapse, the patient has a gravid uterus of more than 20 weeks of size, and mm, up to 5 minutes there is no return of spontaneous circulation, then display evacuation of uterus or emptying of uterus for perimotum cesarean section is planned. What is high quality cardiopulmonary resuscitation in pregnancy? So these are the steps in which the position of the hand is in the sternum, in the lower half of the sternum, and displacing the uterus laterally during resuscitation with rapid chest compression, that is 100 per minute, and the depth of at least 2 inches with adequate chest recoil between the compressions, and minimizing the interruptions between the compression. And also that we will avoid the prolonged pulse check, that is not more than 5 to 10 seconds, and will resume the chest compression immediately after defibrillating. And if there is uh, there can be fatigue, so provider should be switched every 2 minutes. So this is the same thing. Resuscitation will follow ABCDE maneuver. A for airway. So airway will be kept patterned, and also always high flow oxygen should be provided at 6 to 8 liters per minute to maximize the oxygen saturation more than 90 to 95%. Breathing ventilation is checked and supported. Bag mask ventilation, supraglottic airways, or endotracheal intubation may be required with mechanical ventilation. And for circulation, via two wide bore cannula, blood volume restoration to reverse hypertension, and caution should be taken in preeclampsia and eclampsia, and blood arrangement should be done. For disability, we do a short estimation with ABPU, that is alert, verbal, response to voice, response to pain or unconscious, and mental state, bedside blood glucose and pupils should be checked, and exposure should be done in case of trauma. So relieving the autocaval compression is very important with left lateral tilt or 15 to 30 degree of lateral tilt with some kind of wedge underneath will be helpful, and elevation of leg will facilitate the venous return. Foley catheter is done to monitor hourly input output charting, and also ultrasound by a skilled operator can help the diagnosis of concealed hemorrhage, and continuous fetal monitoring and assessment of labor onset and progress is required. But in case of very unstable mother, we don't go with we don't it is not advisable to continue with fetal assessment because we are more concerned with mother. And if mother hypoxia and shock is relieved, then usually fetal assessment or fetal status is also improved. So for management of hemorrhagic shock, we need to identify and arrest the cause of hemorrhage, and if it is the cause of placenta or antepartum causes, then a delivery of the immediate delivery of the baby is required. Similarly, management of postpartum hemorrhage, and in case of ectopic pregnancy, laparotomy is advised. And restoration of blood volume can be done by whole blood, which is cross-matched, and if not available, O negative blood group is used. Similarly, crystallite solution like ringer lactate, normal saline, or 5% dextrose, and excess cannot be given because it can cause pulmonary edema. Similarly, color solutions like dextran 40 or 70, plasma protein fraction, or fresh protein plasma. And in case of refractory hypovolemic shock, we can provide with recombinant factor 8, which will promote aneuploid formation. Similarly, 1 gram IV tranexamic acid has been uh, recommended in case of PPH when given within the 10 hours or within given 3 hours, causes significant reduction in death. So this is the comparative study of crystallite and colloid solution. Crystallite is half-life is less, but colloid half-life is more. So there will be 3 times of volume needed for replacement. But excessive use can cause pulmonary edema, and in colloid, molecules are too large to cross the capillary walls, and it is more expensive, and there is risk of anaphylactic reactions. These are some blood products, that is PRBC or packed red blood cells, which contains of 100 ml of RBC and 40 ml of plasma, and total 150 ml which is used for anemia without volume deficit. Similarly, washed RBC, frozen RBC, whole blood. In whole blood, the RBC is 100 ml, plasma is 150 ml, total is 285 ml, with patients with RBC and volume deficit, and fresh blood of less than 3 days. Volume is similar, but it is useful for newborn, infant, very sick patient with RBC volume deficit. Fresh frozen plasma, which has stable factors, cryoprecipitate or platelet concentrate with 35 ml of platelet. And in case of metabolic acidosis, sodium bicarbonate can be given at 100 milliequivalent. And if the blood pressure is not achieved to a level, or if there is persistent hypotension, then vasopressors can be given like dopamine 2.5 mg per kg per minute, and beta adrenergic stimulant like isoprenaline can be given. And it will, if there is ongoing loss is suspected, then there will be requirement of mechanical or surgical management. Monitoring is usually done with central venous pressure. Central venous catheter is placed, and pressure is maintained to 2 into 12 uh, centimeter of water. Pulse rate, blood pressure, urine output, pulmonary capillary wedge pressure, and clinical improvement in pallor, sinuses, air hunger, sweating, and consciousness. So there is a term called golden first hour and rule of 30. Golden first hour is the first hour in the time in which the resuscitation is must begin to achieve the maximum survival before the metabolic acidosis sets in. And rule of 30 is to assess the severity of shock. It is used to assess the severity of shock. It states that a woman will uh, has to lose at least 30% of her blood volume. Then the systolic blood pressure will fall by 30 mm. Respiratory rate will be more than 30 breaths per minute. Hemoglobin or hematocrit drop by 30%. Urine output less than 30 ml per hour. And if there is one or more of the above, it will indicate moderate shock. The other index is obstetric shock index, that is heart rate divided by systolic blood pressure. In non-pregnant adult, normal is 0.5 to 0.7. In pregnancy, 0.7 to 0.9. And if it is more than 1, then it means the patient needs blood transfusion. So it is also a method of assessing blood loss. The complications of hypovolemic shocks are acute renal failure, pituitary necrosis, which will lead to Sheehan syndrome, and disseminated intravascular coagulations. And for management of cardiogenic shock, usually early diagnosis of cardiac problem like dyspnea, chest pain, or previous congenital heart disease or post-operative case is required. Surgical connection should be done for any operable cardiac lesions like septal defects should be done before pregnancy, and pregnancy or medical termination of pregnancy uh, at 6 to 8 weeks if mm, cardiac condition is not under control, and initial management of shock is similar but further management depends on the cardiac lesions. And so the management of pregnancy is done by expert team of cardiologists with ECG, echo, and obstetrician. In case of antibiotic shock, the basic management is same with ABC. Circulatory management is important, and special aspect is if there is any suspected agent or drugs, it should be stopped and call for help. And injection adrenaline 0.5 ml of 1 is to 1000, and diluted adrenaline should be administered. And early ET intubation is necessary, and Tendelberg position with raised leg, and also vasopressin drugs will monitor BP, rapid infusion of plasma volume expansion with crystalloids. And if it is not, if there is atropine, if there is bradycardia, we give atropine in case of bronchospasm, nebulization with salbutamol or ipravent, antihistamines like IV chlorpheniramine, corticosteroids. Usually, they are giving injection Avil and injection hydrocortisone, dexamethasone, and then immediate referral to critical care unit. For neurogenic shock, basic management is ABC, and special aspect is uh, for circulation, advanced life support with external cardiac massage and defibrillation, and the arrhythmias may be resistant to conventional therapy. We need to maintain blood pressure with vasopressor and ionotropic drug. In case of seizure, diazepam can be given, and in bradycardia, atropine is required. LSCS might be required to salvage the baby and to reduce the risk of awareness. Sometimes sedatives can be given. Septic shock is another deadly complications. Usually, the causative organisms are gram-negative bacilli like E. coli, Proteus, Pseudomonas bacterialis, hemolytic streptococci, anaerobic streptococci, or Clostridia. So this is the picture that shows the pathogenesis in septic shock. Whenever there is any microbial products that release microbial products that release PAMPs, that is pathogen associated molecular patterns, it will activate the endothelial cells. So endothelial cells when get activated, and also it will activate the mm, neutrophil and monocytes and factor 12 complement activation, and overall there will be a cascade of events. So when there is neutrophil or monocyte activation, they will release tumor necrosis factor interleukin 1, and then they will release cytokines or cytokine-like mediators with desire or anti-inflammatory mediators, interleukin 6, interleukin 8, nitric oxide, platelet aggregation factor, reactive oxygen species. Also, with complementation activation, there will be directly or indirectly endothelial activation. Component C3A is mainly responsible, and with factor 12 activation, there will be a procoagulant state with increased tissue factor and a decrease in tissue factor pathway inhibitor, thrombomodulin, fluorescein. So, all these causes will all these will cause increase in microvascular thrombosis, that is DIC, causing tissue ischemia, also adrenal insufficiency and multi-organal failure, and also there will be vasodilation, which will increase the permeability and decrease perfusion, and systemic effects of fever, diminished myocardial contractility, metabolic abnormalities, and immunosuppression can be caused. So the net result will be there will be vasodilation and increased vascular permeability, and there will be profound vasodilation and pooling of the blood, which will cause hyperdynamic circulation, and also there will be increased muscular permeability, which will cause inflammatory edema, DIC, microvascular circulation is prone, and there will be endothelial cell injuries, there will be reduced blood flow, hypotension, and finally shock. So there will be abrupt onset of fever, chills, and tachycardia. So there will be phases like warm phase and cold phase. In warm phase, there is a phase of peripheral vasodilation where there will be tachycardia, hypotension, warm extremities, low central venous pressure due to marked decrease in intravascular blood volume. And in cold phase, there is a peripheral vasoconstriction where there will be increase in central venous pressure due to cardiac failure, poor tissue perfusion, lactic acidosis with tachypnea, acute respiratory distress syndrome, altered sensorium, and DIC. And multi-organ failure can occur due to hypertension and DIC, and acute renal failure, altered liver function test, respiratory failure, cardiac failure can occur. So for management of sepsis, of the immediate response is sepsis 6 or care bundle within 6 hours. That is administer oxygen, start IV fluids, obtain blood culture and swab, administer broad spectrum antibiotics within first hour of recognition, measure serum lactate and monitor our urine output. So antibiotics of choices are usually amoxiclav, metronidazole, clindamycin, piperacillin or tazobactam, and gentamicin. If lactate is more than 4 millimole per liter, there will be rapid administration of 30 ml per kg of crystallite within 3 hours of diagnosis. Then vasopressors, non-adrenaline or inotropes or dovitamin for mean arterial pressure more than 65 mm of Hg. Steroids, if it is unresponsive to inadequate fluid response, steroids can be considered and oxygen saturation should be maintained. And if hemoglobin is less than 7, transfusion can be considered. For fetal distress or unstable mother, LSCS can be done, and if fetal component is source of symptoms, then delivery is essential. When there is retained infected tissues or they should be removed as soon as therapy started, suction evacuation, hysterectomy in advanced infection with gangrenous or traumatized uterus. Some causes like drug overdose or toxicity in magnesium sulfate, 10 ml of 10% of calcium gluconate, slow infusion or 10 ml calcium chloride. In case of local anesthetic, it should be stopped, and lipid rescue in case of collapse. And management of arrhythmia, management of eclampsia is also equally important. Now we'll discuss about some other causes of maternal collapse. That is vasovagal syncope or postural hypotension, ruptured uterus, uterine inversion, amniotic fluid embolism, pulmonary thromboembolism, ear embolism or intracranial hemorrhage, and Mendelssohn syndrome. Amniotic fluid embolism is a rare but life-threatening obstetric emergency in which the amniotic fluid, fetal cells, hair, or other debris material will enter into maternal circulation and cause cardiorespiratory collapse. And the management is usually supportive rather than specific. There is no proven effective therapy for management, and there will be so the diagnostic criteria is there will be clinical onset during labor or within 30 minutes of placental delivery. There is abrupt onset of cardiorespiratory arrest with hypotension and respiratory compromise, overt disseminated intravascular coagulation and fever, no fever more than 38 degrees centigrade. So, coagulopathy will need early aggressive treatment, including fresh frozen plasma, and if hemorrhage is not controlled, then massive blood transfusion might be required with recombinant factor 7A and delivery of fetus and placenta as soon as possible. Some therapies like steroid, heparin, plasmapheresis, or hemofiltration. Ear embolism is another complication in which ear is introduced into the circulation, usually pulmonary circulation, after intrauterine manipulation. Majority there is non-lethal, but if it is lethal, if 3 to 5 ml kg per kg of ear bolus enters into pulmonary circulation, the risk factor is Trendelenburg position, abruptio, placenta previa, extraction of uterus, manual extraction of placenta, severe preeclampsia, antepartum hemorrhage, and hypovolemia. So there will be tachypnea, chest pain, gasping, and investigations like precordial Doppler, thorax, esophageal echocardiography can be done. There will be seldom time for effective management. First aid is patient can be placed head low in lateral position, and aspiration of air can be tried with the discontinuation of nitrous oxide, 100% of oxygen, and flooding the surgical site with saline to avoid further air entry. Pulmonary thromboembolism. So the major consideration should be the major consideration in case of maternal collapse in postpartum period is pulmonary thromboembolism. Usually, there will be sudden onset of dyspnea, chest pain, features of collapse, syncope, cough, hemoptysis, and deep vein thrombosis can be suspected with redness, swelling, and tenderness over pain of legs. And thrombophilia screening can be done for high risk patient, and 1 in 10 patients the fatality is within an hour. So treatment should be started based on clinical judgment without waiting for lab tests. Low molecular weight heparin or warfarin by some warfarin for 3 to 6 months, and it is not contraindicated in lactation. The other cause of acute shock, either hemorrhagic or neurogenic, is uterine inversion. It The causes are spontaneous, mismanaged, third stage of labor, pulling of the cord before placental separation, short cord, or morbidly adenine placenta. It should be managed with resuscitation, IV fluid, cross matching, oxygen, and the patient should be kept warm. The immediate replacement of the uterus should be done without attempt to remove the placenta, which can be delivered later, and uh, or before shock or after shock is treated, and delay can be elevated with the expectation to um, revert itself. The patient should be shifted to OT with broad spectrum antibiotics should be provided, uterine tocolytics or general anesthesia can be given. Manual replacement can be done, that is Johnson's maneuver, hydrostatic reduction, O'Sullivan techniques, and surgical methods like with vaginal and abdominal methods. And after it has been replaced to its position, oxygen should be started to prevent the recurrence. Ruptured uterus is another uh, cause of maternal collapse. The common causes are scarred uterus, in which cesarean section, myomectomy, also obstructed labor, previous manual removal of placenta, dilation and curetage, obstetric maneuvers like instrumental delivery, external cephalic version, malpresentation, over distension, grand multiplicity, and overuse of oxytoxics. So the risk of rupture in case of lower segment cesarean section is 1 to 1%, whereas in vertical incision it is 1 to 7%. Classical J or T, it is say 4 to 9%. Similarly, for 1 CS 0.4 to 0.9%, for 2 CS 0.9 to 1.8%, and if there is short interval of less than 18 months, 4.8% risk of scar rupture. And also sometimes scar thickness can be used for prediction, that is if the cutoff value is 1.5 to 2.3. Diagnosis: usually there is severe pain, unexplained tachycardia, cessation of contractions. The pain is usually continuous, and fainting or external bleeding can be seen. On examination, fetal parts are easily palpable. Loss of uterine contour, that is empty uterus in one side, and scar tenderness may be present. On parvaginal, there is loss of fetal presenting part. Hematoma may be felt, which will push the uterus upwards, and fetal bradycardia, recurrent, variable, or late or prolonged distillation can be present. The management is arrangement of blood and blood products, resuscitation, laparotomy, repair of rupture, or hysterectomy. Now, intracranial hemorrhage. Uh, some causes are preeclampsia, eclampsia, arteriovenous malformation, aneurysm, and trauma. And headache, there will be severe headache, which will be followed by collapse. There can be hemorrhages that will be extradural, subdural, subarachnoid, or intracerebral, and investigation like CT, head, and MRI should be done. It is a if there is neurological emergency, then evacuation of clot is done. And Mendelssohn syndrome is a chemical pneumonitis which is caused by the aspiration of gastric acid under anesthesia. Usually, after 2 to 5 hours of anesthesia, the patient might develop cyanosis, tachycardia, dyspnea, wheeze, crepitant rails, and decreased oxygen saturation. And pulmonary edema can cause sudden death. So, empty stomach, solid food should be avoided during labor, and fasting for 6 to 8 hours. Antacids, H2 blockers before giving anesthesia, Trendelenburg position, suctioning oropharynx, intubation if signs of hypoxia, and bronchoscopy and pulmonary lavage is important. So perimeter cesarean section in women over 20 weeks of gestation if there is no response to correctly performed CPR within 4 minutes of maternal collapse and resuscitation needs to be continued beyond this, then perimeter cesarean section should be done to assist the maternal resuscitation and also sometimes to salvage the baby. It should be not delayed by moving the woman where the maternal collapse has occurred and decision taken in place, and should use the incision which will facilitate with more rapid access, and also scalps, scalpel, and umbilical cord clamps are important. So thank you. I hope this session was useful, and I'll see you in another session. Have a good night.